Hi, good morning, everyone. Thank you so much for joining today. I'm Dr. Sarah Sanchez, and I'm the Medical Director for Infectious Diseases here at the Boston Public Health Commission, and also an infectious disease doctor. Now, we've learned over the past 3 years that public health is certainly not static, and we rely on data from our public health surveillance systems to really track health signals and understand the burden of different conditions on our communities. However, our traditional public health surveillance systems have often required that to generate that data, our individuals or our communities have to interact with the healthcare system, right? They need to get a test at a laboratory, or they need to be hospitalized, or they need to go to a doctor for a medical visit. And yet a big part of what we're discussing today is that most of our communities impacted by COVID-19 and other conditions are often excluded from that very healthcare system. Furthermore, we know that a lot of our data is often incomplete, and that our public health data has not had the full picture or data on race and ethnicity, giving us a very limited picture of the very diversity of Boston residents that we are trying to serve. And so clearly, following the theme of today, we must do things differently. And I'm very honored to have our three panelists here on the stage who have led groundbreaking work over the past 3 years to really implement changes that give us a more full picture in a very rapidly changing pandemic of the burden of COVID in our communities and the inequities that we are trying to dismantle. And so today, as we hear about their groundbreaking work, I also want us to think, again, what do we do differently? How do we reimagine public health surveillance to center community from the onset, to connect with our community, and to really think about, from the get-go, centering our communities and involving in how we collect health data? What type of health data should we be collecting? And again, how we as public health bring public health to those who we are trying to serve to really understand their health needs in a much better way and to address the inequities that we are here to dismantle. And so our speakers for today are Kevin Cranston, Assistant Commissioner at the Massachusetts Department of Public Health and the Director of the MDPH Bureau of Infectious Diseases and Laboratory Sciences. Dr. Elaine Nsoesie, Associate Professor of Global Health at the Boston University School of Public Health. Dr. Nsoesie also leads the Racial Data Tracker Project at the Boston University Center for Anti-Racist Research. And Dr. Kathryn Hall, the Deputy Commissioner for Population Health and Health Equity at the Boston Public Health Commission. And so I am honored to bring Dr. Nsoesie to the podium to sort of start our discussion, and thank you all.
Good morning, everyone. Very honored to be presenting here today after all the amazing presentations that we've heard so far and all the wonderful work that happened during the pandemic. I'm going to talk to you today about the COVID Racial Data Tracker Project and the Racial Data Tracker Project. So at the start of the pandemic, like most people from Black and brown communities, Dr. Kendi was really concerned that the pandemic was affecting people of color a lot more than other racial groups. But he couldn't find the data to either confirm that or refute that fear. And so he began to write about the need for data so that we can understand how different racial groups were being impacted by the pandemic. And he was emphasizing the need for data because that can show us racial disparities. It can also help us identify racist policies that are driving those disparities and can lead us to create anti-racist policies that would allow us to more equitably distribute resources, but also allow us to create more targeted interventions for communities that are being affected. But as I mentioned, this data was not available at the federal level or at the state level. There were some states that were reporting this information, but it wasn't really comprehensive. It wasn't in one place. It was difficult to find. So that led to the birth of the COVID Racial Data Tracker Project, which was a collaboration between Dr. Kendi and the COVID Tracking Project, and became the first project at the Center for Anti-Racist Research. So what the project bring together individuals who were very passionate about collecting this data. So this included journalists, it also included advocates and others in the community. And this data was collected over time, it was standardized. This was manual collection from state websites. And it was standardized and analyzed. And the goal was to compile the most complete and up-to-date COVID ratio data available from state publicly available data. So this is what the data collection process looks like. It was collected through the COVID tracking project at the Atlantic, which was a bigger project. So the COVID ratio data tracker project was within that project. It included a team of trained volunteers who engaged in data collection sessions twice a week. The data was, as I mentioned before, manually collected from state-level public websites. And if you visited state websites sometimes and you've tried to get data, you know how difficult that can be. And data was collected from was collected from 2020 and ended in 2021. At the end of the project, this is what the data looked like. As most of us know, certain racial groups had significantly higher cases and significantly higher death rates compared to others. And this is what the project was trying to show. It was trying to show that these racial disparities exist and that we should be doing something about it. Some of the major findings from this project was that racial data was usually very incomplete. So the data that we were getting from states for some months would include a lot of information about the different racial categories that were being reported, and other cases would include So there were times when if you're looking at hospitalizations or cases of death, you would have some situations where you have 0 individuals classified into any of the racial groups. The state's data reporting methods also varied. So if you go from one state to another, some states will report proportional cases, some states will report the actual raw numbers, some will not report those raw numbers at all. So it was really hard to align this data across different states and understand what different states were showing. States did not also adequately account for the ways in which race and ethnicity can intersect. So you had some states that had 0 data for Latino populations. So they will only report for different racial groups, but will not report for any of those ethnic groups. And states use non-standard racial and ethnic categories, so it wasn't consistent. So you go to one state website and you find that some racial groups were combined, and you go to another state website and you see them separated, and it's difficult for you to start comparing now how different racial groups were being impacted. Some states reported the bare minimum, and states infrequently updated your data. So once the data was there, even if it was incomplete, they didn't go back and try to make it complete, and it also wasn't being reported consistently from month to month. So the team that was working on the COVID ratio data tracker project did the best that they could to align this data across the different states, and we're able to come up with the estimates as I showed you previously. And because at the time, it was the only data source that was showing racial disparities in COVID deaths and cases across the country, there was a lot of people using it. So it was being used in the news, it was being used in academic publications, presentations, and recently I've been learning that it's actually being used in courses, especially in small institutions who don't have the resources to go and find this kind of data and clean it. So the lessons that we learned from the COVID Racial Data Tracker project led to the Racial Data Tracker project. And the main objective of the Racial Data Tracker project is to collect, analyze, and publicly disseminate available racial data that points to the structural nature of racism. This data is available for some of the social determinants of health that we're looking at, but it's scattered in so many different sources that we're trying to bring it to one place, that if someone is interested in learning about social determinants of health or racial disparities within social determinants of health, they can get access to that data. And so we're doing this for the general public, but we're also hoping that organizers and advocates and policymakers can use this data. So if you want to get access to specific data point, you can get that very easily. You can use it in reports or other ways. So the visualization that I have on the screen is an example of the kinds of visualizations that we're trying to create. So we're doing a lot of interactive visualizations, we're creating infographics, and we're gonna make all of this publicly available for anyone who wants to use it. And we'll also have this data in data tables, so you can download them and use them for different purposes. Our initial findings from this project are very consistent with what we found with the COVID ratio data tracker. Data across many social determinants of health that we're interested in are still very incomplete, and they're not easily accessible. It's not always easy for us to download that data. Sometimes we find data in PDFs. If you've ever worked with a PDF, it's really hard for you to extract that data. It's not often it's not possible to obtain reliable data that is disaggregated at the local or state levels, which is very important for policy making. Longitudinal data is not available for a lot of the topics that we're interested in. So sometimes you have data collected for several years in a row, and then it suddenly stops, and you skip a few years, and then you have another year of data, so it's not really consistent, and it's difficult to use. A lot of sources use non-standard racial and ethnic categories, very similar to what we saw with the COVID racial data tracker, and the methodologies are varied, and usually when they describe them, they're incomplete, and it's sometimes difficult for us to understand exactly what was done with the data. Based on all these learnings, we put together a policy report, which I have on the next slide, and made some recommendations around how we can do better in terms of collecting and sharing racial data. And these are just some of the recommendations. There's a lot more in the report. And one of them is recommending that the national government take more responsibility in how racial data is being collected and reported across critical issues. Another is that we start with the current categories, racial categories that we have, and then reevaluate and try to make changes as needed. And so recently, in the last few months, some of our team members have been collaborating with several different agencies, including the OMB, which sets these racial standards or racial categories. And the OMB has had several town hall meetings trying to get input from the general public about what racial categories are important to people and how they should be used in federal reporting. We also made recommendations around providing incentives for states and local participation, also reporting race and ethnicity data as intersecting measures instead of reporting them separately, to tailor privacy-related data suppression practices to the realities of each data, acknowledging that when you make racial data publicly available, some people are going to use it for bad purposes. And so we have to think about that and think about how do we make sure that sensitive information is made private and that people do not misuse it. And we're also making the recommendations, and through the work that we're doing, to make data publicly accessible and available so individuals can use it for different purposes. So the report I mentioned is called Toward Evidence-Based Anti-Racist Policy Making, Problems and Proposals for Better Racial Data Collection and Reporting. It's currently available on our website for anyone who is interested. So if you want to download that, you can download it. So thank you so much. And I'm going to pass it to the next person.
Thank you so much, Dr. Nsoesie. And now I invite Kevin Cranston, Assistant Commissioner, to the stage. Thank you.
I'm hoping that's on. Yes? And I'm very, very pleased and honored to be included in this panel and in today's proceedings. So thank you, Dr. Ochukutu. Thank you, Dr. Hall. Thank you, Dr. Sanchez, for letting me be part of this important day. Makes me very proud to be a Bostonian. I have been asked to walk through a number of data systems, mostly to familiarize yourself with the data sources that have been used at the state level and increasingly at local health level, not only to track the COVID pandemic, but what we have learned and how we have grown some of those data systems to respond to the needs of health equity analysis and health equity response. So I'm going to walk very quickly, and I apologize for the number of slides and how fast I'm going to go through them. We're not going to do a deep dive on the data themselves. This is an opportunity to be familiarized with some of the data systems and some of the data system improvements that we've been involved in. So the first and central source of truth around the pandemic is MAVEN, the Massachusetts Virtual Epidemiologic Network, which has been under development since 2006. We did achieve two major milestones in MAVEN. One is all 90-plus infectious agents and associated human conditions are now fully integrated into MAVEN. This is important for a number of reasons. One, we don't have these siloed data systems in infectious disease, but some disease entities have more resources behind them, such as HIV epidemiology, where we collect much more granular data about individuals, and therefore data that exists in one part of the system can populate data in another part of the system. Much of the data that comes into MAVEN comes only through laboratory reporting, which is notoriously lacking in depth of data, particularly around health equity indicators, and I have more to say about that. And the other milestone is all 351 local cities and towns in Massachusetts are now live on MAVEN. And so this is a bidirectional flow of data. Any data that we get in at the state level is immediately available to the local community where that resident lives, and any data the local community collects is immediately populating the MAVEN system. And the system pulls together lab results, clinical case reports, epidemiologic investigations, and selected medical records data. I'll come back to that in a little bit. Don't worry about the busyness. This is more about what we were talking about earlier, is that when a community member who is seeking a COVID diagnosis largely got those through hospitals, health centers, some of the ad hoc testing sites, or in a long-term care facility. That's the great majority of COVID data that came into the MAVEN system, either from clinical and commercial laboratories. And I want to do a shout out to the Broad Institute for playing a really major role in ramping up the testing capacity in Massachusetts for many partners, or through the state public health laboratory. Most of those data come in through our electronic laboratory reporting system. It's in the middle of the next set of categories. Sometimes we get clinical case reports, and you see ESP in there. I'll come back to that as an issue. Sometimes we just got a flat file, what's called a CSV file, that had to be data entered into the system. So we had folks data entering almost 24 hours a day throughout much of the pandemic. Local health departments, of course, added the data and got data back from MAVEN, as I mentioned earlier. And I want to do also a shout out to the Community Tracing Collaborative, our partnership with Partners in Health, which did a lion's share of the work around contact tracing and case investigation. And just to acknowledge the long list of data consumers on the other side, not the least of which being communities at risk themselves, who can rely on MAVEN data as a source of truth, epidemiologic truth. We did a lot of enhancements. We did over 1,000 releases during the COVID pandemic. Some of it was basic stuff like new diagnostic or test codes, new symptom presentations. We added 1,000 users, particularly at the local health department level. We did institute sexual orientation, gender identity, and expression variables into MAVEN for the first time during COVID. We revised, in collaboration with our occupational health folks, the occupational categories, because clearly occupation was a factor in people's exposure and risk to COVID. We added disability status variables. We did generate initially a daily dashboard, and I want to appreciate Dr. Nsoesie's comments around PDFs and static dashboards, how unhelpful they could be for analysis, and we've gone to a fully interactive dashboard, and I will show you some pieces of that. I'm not going to walk through all the things the interactive dashboard can do, but it changes daily, and it's real-time data drawn directly from MAVEN. This requires, by the way, uploading all of the test results. We have over 50 million COVID test results in the system, and you have to run the data every day to update the dashboard. And I want to do a shout out to my epidemiologist who works 7 days a week. Literally, somebody was working 24 hours a day to keep our dashboards up to date. If you look on the left side, the navigation, these are all the categories of inquiry that you can apply to the COVID dashboard. And then within those categories, you have a number of choices. I've just pulled 3 out as examples. You can go to look at rates, you can look at counts. In this case, we have the death rate by age, as we well know, advanced age, and it's a very sensitive subject for me, having turned 65 recently. is highly correlated with COVID death. In the middle, we have a case rate, cumulative case rate by race ethnicity, as we have known and continue to know that Black and African American, non-Hispanic, and Latino, Latinx individuals have had and continue to have a higher case rate of acquiring COVID in the first place. And perhaps surprisingly, you may see a higher case rate amongst women than men. This may be associated with caregiver roles, it may be associated with occupational roles. In a respiratory infection, we should all be at equal risk. It's simply not the case. It has to be with where you are, how you're interacting, and the opportunities you have for prevention. So I urge you to go to our interactive website and play around. There's lots of opportunity to look at a lot of data in the way that you want to gather it, and it's real-time data. The other major data system that when I first came into the Bureau, what was then the Bureau of Infectious Disease in 2009, I asked then Commissioner John Auerbach, please promise me we won't have a flu pandemic in the first 3 months of my time. And so we waited till April, so it was 4 months into my time, the H1N1 pandemic, and we had no vaccine registry in Massachusetts. We had one, it was inadequate, we had taken it down, we were in the early stage of development, and I want to just call out Bill Adams' work with us, helping develop the system from the very first days. And boy, were we glad to have it for COVID. We had a fully electronic Massachusetts Immunization Information System, or MIIS. Every vaccine that gets administered in Massachusetts should be reported to the MIIS within a limited period of time. It's accessible to every vaccinator, so you can look up people in real time to determine what their current vaccination status is. It's also a repository for individuals to pull down their own records and use them for work, travel, or just to be up to date, school or camp attendance purposes. And it is the primary source for all vaccine equity data. And we have merged, or we have the opportunity to merge data from MAVEN and MIIS because vaccination status was critical to understanding the impact of vaccination on case acquisition and outcomes. So I give you permission to look at my vaccine record for anyone who's worried about HIPAA. I also want to highlight that I waited my turn and got my first dose in April 23rd of 21 when I became age eligible. There's no special privileges in state government. And I want to also acknowledge my 5th dose. I'm now age eligible for an additional booster, which I'm scheduled for this weekend. But this was the verifiable credential. Thank you. If you haven't gotten yours, you haven't scheduled, CVS is scheduling, get on, Walgreens is way ahead of them. I also want to acknowledge that this was a tool for individuals to be able to demonstrate their vaccine status because it became really important for entry into certain locations, for going to school, traveling to your home and back into the United States if you were traveling out of the country. I recognize the limitations of a web-based system to be able to pull this down. We made this a smartphone-based system, and we have a 24-hour help desk to help people access these records. So I urge you to play around with the system to get your own verifiable credential, not only for a COVID vaccine, but everything else that's in the system. And then that we maintain an active dashboard based on the MIIS data. It's part of the overall COVID dashboard and allows you to analyze vaccine coverage by a number of different demographic markers. We keep on the website on a regular basis county-level data by race ethnicity, just to highlight some of those, and the variety of coverage across the state, but some of the excellent work that Suffolk County, in particular the city of Boston, has done. MIAS was one of the sources of truth in making the initial selection of our 20 vaccine equity communities, coupled with population data as well. Those communities had a higher proportion of BIPOC individuals, as well as some of the lower immunization rates amongst BIPOC individuals. Each of the vaccine equity communities has their own section of the VEI webpage, And I don't have to repeat any of the work that the fine panel that you just saw before this talked about, the incredible work working with local communities, faith-based organizations, tribal and indigenous people serving organization, getting vaccine access onto the ground, into the places, and from the people that folks trusted. And so you can click into each of these sites and learn more about the incredible work that's been done with the local health departments and with community-based organizations and community leaders. I just want to highlight on the right side of the graph that the current outcomes that Boston has achieved in vaccine equity have met or exceeded what is the standard in this reporting, which is the statewide average. All right, and so congratulations, Boston and everyone in Boston. I am so proud to be a Bostonian. All right? And so this is real time, so this will continue to update as you continue to make progress. All right, and then I'm going to go to things that are not as useful specifically for equity analysis, but set context against which equity analyses can be compared. One of our mechanisms is syndromic surveillance, where we get automated reporting from a number of participating in hospital emergency rooms, emergency departments, both about the symptom and diagnosis presentations that people bring into the emergency department and whether or not they got admitted for those purposes. A lot of it was built around respiratory illnesses, influenza in particular. We've used it for things like when new things come along, like the EVALI crisis, the vaping crisis, we were using syndromic surveillance to actually try to quantify the size of that problem. Things that you may not imagine you could use it for, like tick symptom presentations, or people who had concerns about a tick bite, and injuries, including gunshot injuries, are one of the things that you can use the system to evaluate. And then we expanded it to include a particular COVID algorithm called COVID-like illness, and it's a set of diagnoses, test results, and symptom presentation. And a subset, and so this is how the tick data would look. It gives you a sense from year to year about the seasonality of tick bites and tick presentations. We also can track COVID-related hospitalizations, and this is part of a national system called the Forecast Hub that actually does some predictive work as well. It helps you look ahead a few weeks and anticipate what hospitalizations might look like in your jurisdiction. But more specifically, we are working with a sort of an offshoot of syndromic surveillance, which is the electronic health record support for public health, working with our partners at Harvard University's Department of Population Medicine. These pull data directly from participating electronic health records. It pulls lab results and diagnostic results and uses algorithms to detect a number of different reportable conditions. It's only things that must be reported anyway. It works particularly well for high volume things that really burden clinicians for having to submit multiple case reports. And it reduces that provider burden, but it also has all the demographics that's contained in the EHR. That's a thumbs up, that's also a thumbs down, right? It's only as good as the data in the electronic health record, and I'll come back to that as a theme. And it does provide, and thank you again, Dr. Nsoesie, about talking about longitudinal data, the ability to look at things over time rather than just as a snapshot, and particularly things like, has somebody been treated for this condition? What were the treatment outcomes? Did the person subsequently, have a relapse or a hospitalization following a treatment failure? So this is the COVID algorithm, the COVID-like illness algorithm in ESP. Many Boston-based or Boston-involved health systems are participating in this COVID work. These data are not going into Maven specifically. They're coming as a flat file, as a separate range of analysis, just because of some validation issues at the moment, but that will change in the future. And just to give you a sampling of some of the data, the bars are the actual test values, volumes statewide, and the percent positive tests in the dark bars. The line graph are the folks in those participating sites who presented and met the COVID-like illness definition. It actually matches relatively well, but in recent months, you'll see the test volumes, because there's so much home testing, our awareness of how many people are getting tested and what their test results are is a less robust indicator. And the COVID-like illness presentation at these sites, this is not just emergency departments, this is any clinical visit, is actually telling a more robust story about how much illness is being reported by these sites. And we are able, because we do have the EHR data, travels with the report, to be able to sort some of these data by race ethnicity. And we continue to see variations and ongoing disparities by race ethnicity, in particular that troublesome category called other. And we'll come back to that as well. Okay, here's an acronym I can't explain to you. The definition is routine, prospective, automated, respiratory virus-like illness, but somehow you got ravioli out of that. This is a little more forward-looking and thinking about, Frank, I'm hard to say it's the next pandemic, likely to be a respiratory pandemic. And we want to look at across all the respiratory illnesses that we track for, even some that are not reportable, and look longitudinally at what those impacts have been. So even a smaller group of individuals have been working with us. This is more experimental than real time. But this is the whole COVID pandemic using the ravioli algorithm. You can see the multiple respiratory illnesses that are being tracked and reported, including a lot of non-specific respiratory illness. If you go all the way to the left, you see first the tail end of the 2019-2020 flu season, normal, and then you get the April bump of the beginning of COVID, right? February through March bump. You see all the peaks. And then I want to draw your attention to the right side. We just recently went through what's called like a triple pandemic, right? Of RSV, influenza, early influenza season, and COVID at the same time. And that was what challenged the hospital capacity and healthcare capacity at the worst possible time. And you can see it in these data. See the stacked effect of these multiple organisms. So more to come on ravioli. We hope to roll it out more widely, and we have a paper in preprint on this at this point. I have to mention wastewater surveillance very quickly. No one data system tells the whole story, but wastewater tells you something you don't get it through any other mechanism, through sewage outflow, and you test for chemicals or organisms, and we have made incredible use of wastewater surveillance as another, again, population measure of what's happening. But the population can be as small as a facility. We're using it extensively in the Department of Corrections and some of the County House of Correction facilities to be able to see what's going on in particularly vulnerable communities in congregate care, or at a city level. Many of the municipalities are looking at their own data, but it's particularly useful looking statewide. In the case of Boston, we take the MWRA has a northern and southern area. This is the northern area that includes all of Boston. This is the entire pandemic since February of 2020, and you can see the predictable peaks that you've experienced. It shows up in the sewerage, right, as it should, but it shows up usually a couple of weeks earlier, say days to weeks earlier than the case rates go up. So it can be an early indicator of a concern. You can't interpret it all by itself. You have to look at everything together. But you can even shorten on our website. You can shorten the time frame and look more granularly at more recent data as we do here. And then there's other kinds of data. We need to know things that are not in the surveillance data set. And I'm very proud of my colleagues in the Office of Population Health and our Bureau of Community Health and Prevention for mounting, it's now since 2020, CCIS, or the COVID-19 Community Impact Survey. It's a convenient sample, so it's not a population sample, but it's very specific efforts were made to reach out to communities most impacted by COVID, working through community organizations and community groups and community leaders. And over 33,000 people trusted us with their personal data. These are qualitative data, talk about the real impact on their lived lives. And I just want to announce that we are in the process of mounting CCIS 2.0. We're still developing the instrument for that to answer critical questions that have been raised by the pandemic. This was performed before vaccination, by the way, just so you know that. But we got such rich data and so much data, particularly from communities that we often don't hear from, that we're able now, these are all buttons that you can push on the website, and you can look granularly at the CCIS data and cross-tab these various factors in terms of populations, geography, and certain topics that were of interest by the survey. And I'm just going to give you 3 examples from the survey. We asked things like, how worried are you about paying your mortgage, rent, or utilities in the next few weeks? This is in the first year of the pandemic, and clearly, non-white communities, BIPOC communities, across the board had higher concerns about being able to pay the rent, pay the mortgage, feed their kids, stay in their homes. Right? Maybe you don't need to be told that, but to have a data point that demonstrates that people are telling us this, I think is important for public policy. We got great response from members of the disability community and people with mobility, and we were able to disaggregate them to some degree. People with mobility disabilities were 60% more likely to have experienced job loss at that moment in the pandemic. And then even though we're in an urban environment, rural clusters, rural communities have their own challenges in response to COVID and other public health issues. And this shows that in various rural clusters of the community, there were differential levels about concern about being able to get food and groceries during the pandemic. So we're eager for your input on CCIS 2.0, which will go beyond COVID alone, and we want to dig into some of these issues more deeply. So challenges and responses. There are so many challenges, and I have a couple of responses. And then one opportunity for which you have one more day to participate. So first of all, the data sources that get into our systems, we have very little visibility of. We don't know how the quality, completeness, the accuracy of the demographic data that's in the electronic health records, that ends up on a test requisition form, that gets into a vaccine registration. The more people do it themselves, the better. The more it's self-reported, the better. It's a data standard, but mostly it's not self-reported. The granularity of analysis, back to other race. We've done so much combining of groups that you lose the individual realities, particularly across some of the smaller racial ethnic populations in Massachusetts. People have intersecting identities that may not be well captured by the standards, and Dr. Nsoesie spoke powerfully to the issues of race and ethnicity being separated, and we've been doing this since 1997 under the Office of Management and Budget standard of race is one thing and so-called Hispanic ethnicity is another, and people don't think of themselves necessarily in those two separate boxes. In fact, have very complex and nuanced understanding of their racial background and their ethnicity, and those are intersecting realities. And then, as we've heard again and again, the mistrust of our health systems, our institutions, our governmental systems, including public health, maybe especially these days, is a factor in people's willingness to share honestly and have their data represented honestly. And then here's the wonky part. HL7 messaging is the electronic way that health records are transferred across health systems and into public health. And FHIR is fast health care interoperability resources. It's an advanced version of HL7. If you want to ask a particular way of being identified, and there's not an HL7 message that transmits it, even if you collected it in your health record, it's not going to get to us. So these are national standards that we have to be about influencing, and this is where your opportunity will come. First of all, I want to really honor and praise former Commissioner Monica Burrell. When she noticed in April, just around the same time you and your colleagues were noticing it, Elaine, that there was a gap in the racial ethnic reporting around COVID. We're at 58% of COVID test results had no racial ethnic identifiers attached to them at that moment. Commissioner Burrell issued a public health order under her authority, and I don't know if you can read that language, but basically requiring expanded demographic reporting, including on laboratory requisition forms, which is where we were getting most of our data. By November of 2020, the missing data had reduced from 58% to 25%, and it continues to improve. We wrote those requirements and some additional requirements, particularly around disability and occupation reporting, preferred language, into our reporting regulations. This became a final promulgation by the Public Health Council in December, this past December. So this now has the force of law in Massachusetts. We've been working for years on, even though it's dated April 2023, it's always real time. We're continuing to work on our race, ethnicity, and language reporting standards. I want to highlight at the heart of this is that self-report is the key, and self-report is rarely the way it gets done. We are still, and this is our Executive Office of Health and Human Services is also working on quality measures to improve health equity data standards. They are still, though, representing that two-part question from OMB's, Directive 15 since 1997 about breaking out race and Hispanic or Latino ethnicity. But they did adopt, and in our own standard, adopt an expanded ethnicity category. And this is continuing to be evaluated to be responsive to how people really think about their ethnicity and give people opportunities to report it. And this is your one-day opportunity because the deadline is tomorrow on this. But the OMB is revisiting the entire category of how this gets collected. And there's some very exciting things in it. One of the things in the OMB draft guidance is the ability for Black and African American individuals to identify as descendants of people who were enslaved and or freed. And this could have real implications for future federal and local policy around reparations and other responses. And it does attempt to merge and integrate race and ethnicity. And so I urge you to weigh in if you have time between now and tomorrow. All right? And I want to thank you for your kindness and attention today. And here we go.
Thank you. And now we'll invite Dr. Hall to the podium. Thank you.
Thanks, Dr. Sanchez. And thank you, Kevin, for all that you've done, because we literally are standing on your shoulders in the work that I'm going to be presenting at the Boston Public Health Commission. I'm going to focus on 4 themes that really used some of the data and created our own data that we used to understand, to basically track and translate the risk that we were seeing to the communities. And I'm going to talk about our local Boston Wastewater Initiative and how we really went from data to policy, and give you an example of masking in Boston Public Schools. So I want to take a moment to just take a look at this slide and the next slide, because what we're looking at here are the excess deaths caused from COVID in 2020 and 2021. Between 2019 and 2020, there were 30% more deaths, in large part due to COVID. That's that light blue piece on top of the dark blue piece there in 2020 in the middle. And it got better in 2021, but it was still 10%. And when we break this out by race ethnicity, we really see these striking disparities, not only in cases of COVID, but now we're talking about death. And I want to take a moment here to just reflect on the work of our epidemiology teams. We have amazing teams and we have amazing collaborators, and you'll hear about some of the collaborations that we have in a minute, but we never think of these as just numbers. 42% more deaths among African American, among Black people in our city in 2020. 44% more among our Latinx residents, 16% more among our white residents, and 46% more deaths due to COVID. If anybody in this room has somebody who they know who died from COVID, you know how painful these numbers are. And we take really seriously the actions that we take to intervene, to change this, and we're really grateful to see them drop in 2020, in 2021. But I want you to know that this is how we use the data. We don't just collect the numbers, we figure out where we're gonna go, where we're gonna bring those vaccination clinics, where we're gonna bring those testing clinics, where we're gonna make tests available to the community, and how we're gonna inform them about these numbers and how they can take care of themselves and protect themselves. We talked a little bit about Mattapan earlier, and you can see here, these are the excess deaths by neighborhood in Boston. Mattapan had the highest percent excess deaths, 17.1%. Back Bay, the lowest. Again, very striking health inequities across the city, but no death is okay. So how did we communicate the complexity of these numbers? We have some great fellows, and one of them is sitting here, Dr. Tori Cugger, created this triptych. And you might look at this and say, oh, this is a graph, what is this? But I want to tell you about this because it's a tool that we used to educate the community about what we were seeing. And what it did here, these 3 simple graphs, or sometimes not so simple, but we used them to decode the complexity that was coming from the CDC. The CDC was giving us a lot of, complex, sometimes mixed signals about how to tell where we are. And finally, they kind of distilled it down to the middle graph and the graph on the far left. So cases per day and hospitalizations, because that's what would really impact the hospital systems, the healthcare systems, and that would really kind of impact people's ability to get care. We were lucky enough to have the MWRA work in wastewater surveillance, and that's the first graph. And so together we tracked this wastewater cases and hospitalizations, and we taught our community leaders to read this graph. Every week we sat with them on a Wednesday, Melissa, Hector, and I, and we walked them through what we were seeing. We told them about the new variants that we were seeing, and when it came time and we got money from ARPA, we put wastewater in the neighborhoods across the city, so we weren't just reliant on the broad Massachusetts broad strokes, but we could tell you more or less, at least with more accuracy, what was happening in your neighborhood. So one of the themes that you'll hear a lot today was collaborations. So we didn't only have academic collaborations, we collaborated with some really great companies. And one of them was BioBot, which is a startup in Cambridge, a brilliant company led by women, which is amazing. And they devised this system where they put these little, bots into manholes, or I'm told not to use the term manhole, but it gets really problematic when you start to think what the alternatives are. So these sewer holes is what I'm told to say. So yeah, there's no equity around that manhole term. We just, it's complex. So anyway, they would put these bots in, they would sample the water over time, and then with another company, Flow Assessment, and also in collaboration with our Boston Water Authority teams, we would get these and sample them. We placed them in 11 neighborhoods across the city, and here are some of the neighborhoods. And this led to some really interesting information that we kind of dug up, pardon the pun, on the Boston sewer system and kind of the history of the sewer systems. We had many interesting challenges, like where to put these, which manhole, sewer hole to go into, because we really needed to avoid, for instance, having police details in busy neighborhoods. But we were able to finally figure it out, and we were able to now provide to our communities, to our teams, Melissa Hector was heading vaccinations clinics. Where do we need these vaccine clinics most? And here on the left, you can see the neighborhood trends over time in wastewater. So how much COVID is in your neighborhood? So again, people in Roxbury, people in West Roxbury could go here and understand how much COVID they're getting exposed to in their neighborhood. We also track trends over time for the whole of Boston, and we also compared that to the MWRA. Boston was always higher than MWRA, which was really interesting. We're more dense population. I guess it's not that interesting if you're not really into this burden of virus in the wastewater. Anyway, we also were able to look at the variants in wastewater, and I can tell you now that XBB1 is the winner. There's a new variant on the horizon, Arcturus, but Kevin assures me that we don't have to worry too much. So beyond the wastewater and beyond, the viral exposures, we really were, I think, at the commission working with community to get protective gear into the community. So face masks. But do face masks really work? And we all know what they say on Twitter about face masks. And when we had a wonderful opportunity to build a team, Natalia Linos, Mary Bassett here, Tori Koger, Ellie Murray over there in the back, and Dr. Sanchez, Jalen Clark, and Dr. Ojikutu, we came together and we took advantage of a really interesting moment in time, which was this rescinding of the masking mandate. In February of 25th of 2022, CDC removed the universal masking mandate from K through 12 public schools, and not everybody in Massachusetts did it at the same time. So there was this staggering, this moment where some schools took it off and some schools had it on, and really we had the opportunity to measure the effect of masking. And we did this really fascinating study using this methodology called the difference of differences. And what we found was, if you can see on the right side of this graph, the lines for the rates of cases among schools based on the week that they unmasked is on the right hand of this graph, and on the left is the time after they unmasked. And what you really see is the schools that unmasked sooner had higher cases of COVID. And what's really amazing about this is Boston and Chelsea were the only two cities in Greater Boston that kept masking on the whole time. So basically, Boston was really, and Chelsea saw significantly fewer cases of COVID among our staff and students here. And we were really, I think this is really important because many of these, there were, and I just want to tell you what's on this slide, 45 cases per 10,000 staff and students were avoided, which is amazing just from a simple mask. Mask is some of the oldest technology you can get, and it's relatively inexpensive and relatively accessible to most people. And because of this simple intervention, we were able to protect students that were in schools that had more crowding, students in schools that had worse HVAC systems, many of these students are students of color, and their staff are students of color. And so with these simple technologies, I think, were able not just to collect the numbers, but to have an impact on people's lives. And we must always remember that, I think early on people thought, oh, kids don't really get that much COVID, it's not gonna be a problem. But every kid that gets exposed goes home. They go home to a parent or a guardian that is working and maybe elderly in their homes, and so they can spread COVID. They can also get sick, and if they're sick, they had to stay out of school, so they lost in-school days. And as you know, one of the great drivers of health inequities is lack of education, poor education. And so COVID was another opportunity to not just cause, death, but to introduce more setbacks in education. And so here's a simple technology again that I think really made a difference in the lives of our residents in Boston. So I want to just end by saying that these advances in data acquisition and processing were really, I think, a key part of a comprehensive COVID-19 strategy to reduce disease burden on the many communities historically marginalized by structural racism. And I want to just end with another, and hopefully this joke is not in too poor taste, but I just want to say that an economist, and this actually is a true story from our group, so I won't say any names, so I'll tell it like this, but an economist and an epidemiologist go to a bar. And the economist says, I don't know why you're doing all this work, because it just comes down to money. It comes down to housing. It comes down to education. And it's not about health. It's about, the social determinants of health are really about money. And the epidemiologist said, that's why we're here, because we fill that gap. We find out where the gap is, and we get interventions in to fill the gap while we try and get all the many ways that you've heard about to get the money in place to do the work that we have to do. So I want to just end by thanking the amazing team at the Center for Public Health Science, Technology, and Innovation at the Boston Public Health Commission, and our amazing team of collaborators that help us do this work and really help us broaden our reach and what we're capable of doing. Thank you.
Wow. I firstly just really want to commend our panelists, their organizations, and our organizations, including everyone across the Boston Public Health Commissions, our bureaus, our public health service programs, and even Boston Public Schools, which we named as a partner in sort of collecting this data, and our community partners, right? Because I think we've seen not only the diversity of data that we've collected, but the sheer work and sort of the passion underlying that work to really serve our communities that is required for this type of effort. And we have a fairly limited amount of time. We have 2 minutes, but to be exact. But I think we've, in seeing and kind of building on Dr. Hall's ending point, we've seen all the work that we take to generate this data. And I want to sort of think about, as we end this panel, a call to action and question that I'll pose to our panelists as well as the audience. What additional steps do we think are critical to make sure that the data that we're generating makes it to our communities, right? Gets in the hands of not just our residents, but also our policymakers that can really help us to enact change. And so what do we think are some of where do we go from here? And what do we do differently in public health surveillance and data?
Well, I'll just jump in because I truly enjoyed our Wednesday meetings and enjoy them. They're still ongoing, although we're trying to think what will we talk about when there's not that much COVID around. Obviously, we're going to be talking about health equity, but I think it's really critical to have the collaboration, the connection, the ongoing discussion with the community, to ask them what they're seeing, to share with them what you're seeing, and to co-create the interventions of the future. I think it's, we've seen it here. It's absolutely indispensable, and it's the only way to go. And I just want to touch on one thing, because as I'm sitting here, I hear people talking about community and talking about, the academy, and it's so interesting how we really are spending the day putting each other in boxes, whether it's, the box of Asian or the box of Latinx or the box of academy or the box of community. And I really want to just echo back to what Lesh Nolan said is, I think she's kind of cracking that code with having the young people in the organization learn and become the future physicians, become part of the academy, because then the community is the academy, the community is the health center. And I think that's really where we need to go in the future with this.
Thank you, Dr. Hall. Others among the panel?
I think my views are the same as Dr. Hall's. Within the Center for Anti-Racist Research, we have 4 offices. We have an Office of Research, an Office of Policy, Advocacy, and Narrative. And so to build a racial data tracker, what we've been doing is working closely with our Office of Advocacy, because they do a lot of the work with communities. And so they tell us what communities are interested in, so we can focus on that type of data and present that data for them to see. And we're hoping to continue doing that work in the future.
Thank you.
Very quickly, I think the community should be guiding us about what we collect and how we collect it, and then should be the first respondents to the data to help us understand what it means.
Thank you. So I really want to thank our speakers so much. I don't see any hands in the, oh, actually I do, in the back. Hi. Can you introduce yourself and a question? Yeah.
See, there's a mic for you.
One part looking forward is, given that it is likely that in 2024 OMB will change the racialized ethnic categories that are being done, what work is being done here to anticipate that because of the transitional data that's needed to make sure that there's continuity so that we can really be monitoring things correctly? That's one big piece. But the other is that I continue to be struck by how the data that are collected and reported very much depend on individual level data. But we live, as was repeatedly emphasized in the morning's panels, and now, people live in real places and they live in communities. And I am wondering, to improve the health equity component, and this is stuff that I've do my work on, and speaking from that vantage, to report people's data not only by who they are, but the census tract characteristics of where they live, to bring out the racialized economic segregation that permeates Massachusetts and every other place in this country, to have it so that you all never just have the data that are focused on people who are most harmed, but also bringing in the right comparison groups of the people, back to the point that was made earlier, of who is actually benefiting from the ways things are. So I just think that it's really important, as these data go forward, as you're working with electronic health record data or others, there are residential addresses. They can be immediately geocoded. They can immediately be linked to census tract level data. There are very useful metrics to use, and it's not, and to stop the thinking that that's somehow ecological data, which is a misuse of the term ecology anyway. It's community-based contextual data that ought to be there so their comparisons can be made. So then when you're talking about preventable loss of life, really showing what the comparisons are, that it need not be this way.
Boy, I'd love to take this on in a really thoughtful and ongoing way, as we have for decades. So first of all, I think data standards are critical in order, and that across our data systems, and several of the systems I just described do not have consistent approaches, right? And so there is work in anticipation of the OMB's work to establish, at least at the Executive Office of Health and Human Services, a set of data standards that all of our data systems are held accountable to. It's going to take a lot of recoding of our work, so just to anticipate that. And I just want to say one word about self-report. Every time I go to a primary care doctor appointment, I get sort of shuffled over to a little booth, and I have to talk to the billing person, and I have to confirm my address and my phone number and my insurance and all that. Wouldn't that be a wonderful opportunity for me to reconfirm my identity? Because when we get into these much more granular identity labels, it's going to take a conversation with somebody to say, why are you asking this? How do you really identify, and make sure that gets captured accurately in my health record and in other records. And I appreciate it. We've done a lot of work around utilizing the Social Vulnerability Index as one of the ways, down to, it's not a perfect measure, but it's a standardized approach, at least to be looking at zip code and census tract as a contextual reality to the information about the individuals and groups of individuals. But boy, are we looking for a more standard and powerful tool to talk about economic disparity as the primary driver of the health issues we're analyzing.
Hi, yes.
I can speak loud.
Yes, go ahead.
Very simple question.
Thank you.
And I'm speaking from Boston. Our issue wasn't getting the data. I think we had amazing data, like on a weekly basis, because of the structure that the city of Boston put in place early on. The challenge for us is what to do with it when we got it. What the process of using it to move people. And the data that Dr. Hall showed was what we talked about every week, the power of the numbers. You know, they were tracking weekly. We could go then and tell people that we were the only community that was dying at a percentage higher than our very population in the city. And we had numbers. And the city kept those numbers for weeks. I think it was 122 weeks when I stopped counting. When I say we, Black residents of Boston never moved from the #1 spot. There was never a week when we didn't have more Black people dying than any other population. And like I said, we were 24% of the population. We kind of peaked and stayed at 32% to 40%. No other. Those numbers should shock us, should move us, and say, what do we got to do to change those? And it didn't. So again, I just say that the issue for us was not getting the data. It was, what do we do with it when we get it? And we should be focused on that.
And just building on that, I mean, I think your point is even more poignant because the numbers are still with us. It's not like you got the data before, it's that the data is here before you. The data that Dr. Ojikutu showed this morning shows that this is happening in cancer, heart disease, diabetes, it's still here. So, you know, I think the question remains, what will we do with the data?
Thank you. And on that note, I really want to thank our speakers and our audience for this fascinating, forward-looking discussion. And now it is lunchtime. I do ask you can please pick up your bagged lunch in the McKim Exhibition Hall, back where you've registered. There are a few options for where to dine, either here in this room, in the McKim, where you will pick up lunch, or downstairs in Conference Room B, or outside in the courtyard if it's a lovely day. Most importantly, we will meet right back here promptly at 12:30 for our keynote conversation between Kate Walsh, our new Secretary of Health and Human Services, and Dr. Ojikutu. So we look forward to seeing you then. Thank you.